Hello and welcome to the Rural Doctors Programme, a special discussion on motivating behavioural change using brief intervention therapy and other techniques. But before we get into that and introduce our panel, a quick word about our upcoming conference.
The Rural Health West Annual Conference and Trade Exhibition is on again. The theme for this year's conference is Children of All Ages, Healthcare Across the Continuum in Rural Communities. There's a great lineup of keynote speakers and there'll be some clinical updates as well as some hands-on workshops and paediatric case studies. The conference is also a perfect opportunity to catch up with colleagues from around the state. So visit the Rural Health West website to download the program overview, and while you're there you can register online. We'll also be holding the Rural and Remote Retrieval Conference this year in the beautiful Karijini National Park. The conference offers a unique opportunity to practice wilderness and emergency medicine in a truly amazing setting. This year the conference is scheduled from the 16th to the 19th of May and numbers are limited, so if you're interested, registration forms are now available on the website. The Aboriginal Health Conference will be held on the 6th and 7th of July this year. This leading conference is a must for anyone with an interest in closing the gap in Indigenous health. Abstract submissions are now open, so please visit the website to download the submission guidelines and an application form. Or if you want something a bit different, Rural Health West is also seeking expressions of interest from doctors for a new conference in 2013, the Remote Coastal Emergency Medicine Conference, to be held at Narraloo Station. The focus will be on emergencies in the marine setting, so if that sounds like something you'd like to be involved in, then please contact the Rural Health West Events Coordinator to register your interest. And if you get a chance, it's worth having a look at all the events in the events calendar on the Rural Health West website for details of any CPD opportunities we have available. And we're looking forward to seeing you at one or all of our conferences this year.
Motivating behavioural change using brief intervention therapy and other techniques is the topic of our conversation today. We're joined by Dr John Forbes, who's a clinical psychologist practicing here in Perth and specialising in positive psychology. And joining him is Dr Jenny Fay, who's a GP based in North Perth. And also joining me, asking all the difficult questions, is Dr Olga Ward. Welcome to all of you.
Morning, Jenny.
Morning. Morning, Gerry.
Brief intervention therapy, what exactly is this, John?
I think it depends a little bit on your perspective as to whether you're a medical doctor or a psychologist. From our perspective, a lot of what we're doing nowadays has to be a brief intervention, simply because of the restrictions placed on us by Medicare. But we're generally talking about 10 to 15 sessions with a psychologist would be considered a brief intervention, because if we're dealing with things such as personality disorders, you're really looking at 1 to 2 years at a minimum for those sorts of interventions.
So Olga, how do we take that and then translate that to the work of a GP in terms of motivating behavioural change?
Well, for a GP, I think brief interventions are talking not so much of the length of the course of therapy, which is what John would understand, but for us it's trying to jam some kind of psychological support, usually for behavioural change and sometimes for a psychological condition, within the constraints of a 15 to 30 minute consultation at level B or C. Quite often this is the by the way doctor thing that you know as a GP is going to be extremely important for the patient's future and for the patient's lifestyle and for the way the patient's health and well-being is managed as distinct from the illness that you're treating today. But you've only got that tiny little time.
But I think it's also seizing the opportunities to jump in where it hasn't been raised. Yeah. And perhaps our time accrues over 20 years as a GP, hopefully, where we add up all the little bits over 20 years and you're seizing moments as they arise in a consultation, or as it may be a sideline or associated factor on the presentation of that patient.
But as a layperson, whenever I go to the doctor, which is a couple of times a year, for a bloke, that's quite good, I believe.
Quite good.
It's like the doctor says, what can I do for you today? And so you go in with a specific ailment or complaint because we know we've been sitting in the waiting room we had an appointment at 10 o'clock, it's now 10:30, the doctor's running behind, there isn't a lot of time, you're conscious of not taking up the doctor's time. So very often I will present with a sore thumb, but in actual fact there's something else behind it. As a GP, how do you detect what's behind this?
Yes, I think it's partly in detecting what's behind it, but it's also partly what's in the back of my head. And there's always another agenda in my head as well, going preventive, preventive, preventive. You know, is it smoking? Is it a tetanus shot if it's a sore thumb and you've injured it on the farm? You know, there's preventive and other changes to be had in there. So yeah, it's always you know, if it's a simple presentation, sometimes that is all it is. But if other times it's a question of just opening the door a little bit, saying, so while you're attending to a sore thumb, well, how are things on the farm? What's happening? You know, how's everything going out there? How's mum? How's dad? How are the kids? Just opening the door a little bit.
By the way, I note that you are sunburnt or in your 60s or in your 50s,
yes.
And you know,
But
we
Olga,
usually do screening tests for people in this age group. Have you thought about cholesterol, smoking?
Sure.
Those are the little kind of ins. You know, you try to open those doors, and you just have to hope, particularly I think with farming patients, and also with the fly-in fly-out miners, quite difficult because they're not always in town, and those towns are so underdoctored. But you need to make a series of appointments often to address this.
And it's quite legitimate to say, look, we need to talk about your cholesterol, you need your prostate test done, you know, you need to just look, we need to talk about your weight, how would you feel about coming back to talk about that? That's fine. And frequently I would work that way, you know, frequently.
But do you feel under any pressure, you're a practice manager, you know, you're a half an hour behind because you've had you know, and so do you feel the pressure to get this over with so you can catch up some time?
Yes, you do. Of course you do. But I also think, you know, there's a certain pride in that, you know, that in that you know you have to do those things. And there are some days I'll have to say, we need to talk about this. I'd love to see you. Are you interested?
Yeah.
That's a crucial question. Are you interested? You know, if so, yes. Can we set aside a time for this?
So your initial assessment is, apart from the sore thumb, is a quick scan of the entire person.
Pretty much. I mean, you know, there are days where that happens well. There are days when it doesn't. But yes, I think I'm looking broadly at that person and saying, what haven't we done lately? You know.
Yeah. So John, who would you say are the patients that are most suitable for this kind of brief?
Well,
You know, who are the ones that we know are going to be quite good responders? And have you got some introductory one-liners that could maybe get us in with the patient that would get them on side and bring them back?
Well, the beauty of it is, if we apply a technique called motivational interviewing, really all you need is one-liners. Because the idea behind motivational interviewing is that you want the patient to think and you want them to talk. So if we're doing our job properly in this context, we're being very quiet indeed. Really, the rule of thumb in terms of who's going to benefit from this is essentially, if you can't medicate and you can't operate, then you can use these techniques. So where someone has to change their behaviour in order to improve their medical condition, this is what you can do.
So is there one key question or type of question that you would suggest to a GP to ask, which will open the floodgates, as it were, or at least get the patient communicating as opposed to just mouthing words?
Yeah, it really involves asking open-ended questions that examine two areas. First of all, we assume that the person is concerned about their condition. And if they're not, by asking them simply, what concerns you about your condition, we're making them think about that.
You disagree with that, Jenny?
That's half the battle. If I had that patient, I'm really happy.
Right.
Because that patient's come to me at a BMI of 35 going, oh, this is just rubbish, I need to change. The problem is they come in actually for their blood pressure script, and I want that agenda.
So that's that type of patient that Olga asked about, the person who suited best to. So that person is open to talking about it.
Someone's asking.
But this is where they don't need to be open. So ultimately what we need to create is a thing called cognitive dissonance. And that is, we need to get them to think about what they want to achieve, how their life is going to be if it's better, and directly compare and contrast that to what they're going through now. And part of our job is going to be highlighting the risks of continuing their current behaviours. But unfortunately, what a lot of people don't do is give any consideration to what a good life looks like. I mean, I see people all the time, and everyone can tell me what's wrong with them and what they don't like about their current situation. But I need to also ask them, well, how would life be good for you if you made a change? Because rather than having a goal, a negative goal that they're repelled from, we need to get them clear in their mind about what a positive goal is, one that they're attracted to, because that's going to maintain that positive change behaviour.
Now, what about the patient? And I guess, Olga, this would be typical in farming countries in particular. One, they're busy. Two, their care is about people other than themselves, blokes in particular. And a lot of work has gone into making men start to take their health a bit more seriously. How do you approach a male patient in a country setting who wants to talk about anything other than how he's feeling?
Look, the short answer to that is get them talking. I can vividly remember one of my professors when they were asked the question in a first year postgrad, what do I say, what do I ask? And they said nothing, just get the person talking, because you'll always get to where you need to go. And people are going to share information about their life, and a lot to do with applying motivational interviewing techniques. So really just subtle changes in our conversation. So rather than asking, so what about the Eagles or the Dockers or something like that, you ask, what difficulties have you faced? So if you have a BMI of 35, how is that affecting your life right now? And how would you like your life to be different? Have you given any consideration to what you would need to do? And even if they haven't, the intention of asking those questions really forces the person to start thinking. And if we force them to start thinking, they move further around a stage of change continuum that I can go through if you really want me to. But our job as part of this is not to actually implement the change, it's to create that cognitive dissonance, that feeling of discomfort between where I am and where I want to be or where I need to be, and that can only be achieved by getting them to think about things and asking them those sorts of open-ended questions.
Can you start by, I find it quite useful just chatting with my patients about things that are completely unrelated but are related. How's the farming season going? Exactly. How's the new grandchild? There's all those other little questions that kind of get you into their life. I guess you can then step off from that into the how is your life
Part
going?
of the difficulty I think I find in some of those techniques is my patients are long term. I've been a GP for 20 years. How many times can I open the door? And I know they're sick of me asking, or offering to say, look, would you interested in doing something about your weight or your blood sugars are not well controlled? How interested are you? And I struggle then with, I know they're getting frustrated, and the most frustrated ones in the end will leave and find a doctor who won't ask about those tricky things. So, how do I approach that long-term patient?
We can't force the issue, ever, and if someone is highly resistant, we need to do work on that, and it may be best to refer them to a psychologist. Having said that,
and then
we get a goodly number of people who...
And then they'll definitely go and find another doctor.
That's right. I mean, when it comes down to it, if you picked someone at random on the face of the earth right now, out of 7,500 million people, I can guarantee that they're only doing what they're doing because they think the benefits outweigh the costs. Now that may be because they haven't given any thought to the costs, but they think it's easier or better for them to just do what they're doing.
Or they're too frightened to make the change
That's
for
right.
whatever reason.
But it's over there, I'm not going to worry about it. But in essence, I'm better off not stressing about it. And when someone is stuck in a long-term problematic behaviour, one of the things that we can help them with is to become aware of why they're doing this and what they think the perceived benefits are, even if it is one of avoidance. And then knowing that, we can actually start targeting and tailoring our questions. And they just need to be, all you need to do is ask one question. And the research in this is very clear. 6 minutes of motivational interviewing interventions, asking a question and getting the person thinking, is sufficient to initiate change.
How do you do that in such a short space of time? A GP can have 15 minutes in order to make this happen. What are the buttons that you press that quickly that can elicit that kind of motivation?
You ask them questions about essentially thinking forward in life. So someone's just had a grandchild. What would you like to do with them? Do you want to be around to see them grow up? Do you want to go to their wedding? That sort of thing. So ask them about how they want life to be, well, the sorts of things they want to be able to do, their ultimate life goals. And then we have an opportunity if they say, oh, yes, I'd love to, you know, well, what do you think is going to get in the way of achieving that? And if they really don't know, then we can start saying, well, you know, is it okay if I share some of my concerns with you, because I can see some things that are potentially getting in the way. But that all helps to also establish that positive goal that they want to achieve. Because if there are some things that are going to compromise their ability to get there, that's what we need to help them with.
Jenny, the recalcitrants that you speak of, those, what percentage of your practice would be made up or comprised of those people?
Oh, of my long-term patients, probably a small minority. You know, I mean, I think we affect change in most people, or reasonable change at least in most people, because you have these long-term people. You know, it's not a new patient. If it's a new patient, that's sort of easy. This is a fresh blood. I can open the door here and say, hey, what's on the table, you know. But my long-term patients, they're the harder ones in a way.
Now, Jenny, you had a story of a reasonable success that you've had with making some behaviour change. Could you maybe go through that case and we'll see if we can pick out what made it such a success? Okay.
Well, I've got Mr James who sees me, who's about 60. He has...
Mr James, whose name is not Mr James?
No, that is definitely not his name. He actually presented saying he please would like a full body PET scan, very expensive procedure, because he was concerned about cancer. In fact, he's a very well-off businessman. He's got plenty of money to burn. He eats out business lunches every day. He drinks about 6 glasses of wine a day. He's not non-smoker. His BMI was around the 30-31 mark, and his abdominal circumference was raised about 110 centimetres. Slightly elevated blood pressure. And so really the question then is, what's going to be most appropriate to this man? Where does this man's risks lie as a GP, and do they really lie in a cancer direction? You know, I asked a few questions around. There wasn't any great reason to fear that. He just thought, well, he'd heard about this great test and perhaps he'd like to, you know, take it. So, you know, we check around, they go, well, where do your risks really lie, Mr James? And of course they really lie in more of a cardiovascular risk to this man. You know, he had a bit of a family history of cardiovascular disease too. So we did identify, he did self-identify his drinking as too much, you know, but that was what he enjoyed. His benefits were business. He, you know, that was his social lifestyle, and his business lifestyle involved business lunches. That's how he did his work. And so then it involved just addressing whether he thought he could make a change to that, whether that would be working for him in his business settings. It took a long time, you know, but over the course of 1 to 2 years, definitely we've made changes with him. His BMI has come down, his blood pressure's actually not required medication, it fell back into normal range, and he's not stopped drinking, but he's certainly reduced it a lot. And he learned to be a bit more upfront with his business colleagues to say, I'm not going to drink at lunch, hope that's okay with you. And it was actually, he was surprised, it was very well accepted.
So he was one who actually offered himself up, if you like.
In a sense.
He had self-identified that he had an issue.
No, he didn't really.
Yeah.
He came in saying, I'd like a cancer checkup.
Well, therefore he had some concerns.
No, he was just a bloke who thought that a PET scan, he'd read about it in the paper, thought, I've got lots of money, I can pay for one of those, I'll have one of those tests, and you know, you can check me out.
You know, the job of the general practitioner there is to raise the patient's awareness of what their real risk is, because one of our chief jobs really is interpreting information
For them.
in a format that a patient can access.
But there are, while that businessman had some sort of smarts to say, I want this particular test, which of course led to a whole lot of other things, there are people walking about in our society who are heart attack, stroke potential victims waiting to happen. These are the people that cause, you know, this is the biggest problem. Am I right, Olga? These are the people who haven't actually put their hand up and said, I need a test or whatever.
Well, there's people who are unaware of their risk, and then there's people who are aware of their risk but are frightened of what making a change might mean for them in terms of what's it going to cost me in time, in effort. Quite a lot of my patients will say, I can't exercise because I can't afford a gym. And I just look out the window and think, what's wrong with the footpath? And then I think, get a Kelpie or I'll lend you mine. Because that'll solve your exercise problem on the spot.
That's an important point, because people do have a lot of assumptions about what it's going to take. And you know, I routinely encourage people to engage in exercise, But the sort of exercise I want to encourage them to engage in is actually very low level. But as soon as I mention the E word, everyone thinks about pulling on lycra and a headband and hitting the gym.
Could I ask both you, Jenny and John, sometimes as a GP, you don't have success with motivating any behavioural change. I think that makes a GP feel a bit of a failure.
I'll give the GP perspective on that. I would agree, and I think there is, to some extent, a degree of acceptance that I can't change everybody, and I can't motivate everybody to take change on board. And that's okay. I will keep trying, but I will have a point where I will know that it's my value can't be measured by how well my patients are doing, and that I'm still doing my work and I'm doing my best work, even if those outcomes aren't what I would like them to be.
And look, I think the key word you've used there is acceptance. We need to know our limits, our boundaries, but oddly enough, accepting the other person for who they are can sometimes motivate them for change. So if we don't get into these sorts of keep trying harder battles because I'm really interested in your outcome, that can actually liberate them.
Yeah, and quite possibly with that acceptance may come a little bit of change from that patient.
It's a very fine line between an acceptance of that but not pandering to their needs or their wants, if you like.
It's respecting ourselves as much as anything else. It's GPs aren't in an exclusive club here. I see a lot of people who drift off into the ether, unfortunately, and I'll try and follow them up. But ultimately, I have to accept that if nothing else, now wasn't the time. They weren't ready now. Hopefully, at some point, they'll want to re-engage and continue that change process.
And do you articulate that to them?
Yes. Absolutely.
So, you know, maybe now is not the time to make these changes, but, you know, there is a process when you are ready to engage with it. Jenny, would you also articulate that sort of thing to your patient?
Yes, I'm probably not verbal enough in that, and perhaps that's something I can take on board as a GP, is to say, we've tried hard here, let's take a break if you like, or, you know, if this is not the good time for you, why don't you approach me again when you feel ready to contemplate this again in the future?
So you're empowering them basically to make the decision for themselves.
And we're calling a halt to let's stop practising failure and wait until you're ready to start practising success.
And we'll come back to that discussion, but right now we're going to hear from Dr Tim Leahy and Lynn Dimer from the Heart Foundation as they look at aspects of cardiovascular health in Indigenous patients. We'll be back after that story.
Okay, so you're Bruce's mum, eh?
Yeah.
Right, so how's his family going? Because I haven't seen Bruce in...
I guess one of the first things I think about in doing any brief intervention with an Aboriginal person is creating some trust and connection. I don't think it's even worth trying a brief intervention if there's no basic trust and connection with the patient I'm working with.
It's so important that if you don't have that trust, you're not going to get the responses that you actually want to happen. And also having that trust, the people will know and confide more information to you than they would normally do. If you don't have the trust, they'll tell you exactly what you want and no further, so you can't really get change happening, and you can't even begin to make small steps into getting people to working with you.
When I start a consultation, I'm saying hello to the person and trying to be warm and friendly. And often I'll be asking a question about how they're going and also how are members of the family going. There's often some news, something that's important to know, and it's important to show that you care about not just the person but the extended family.
You've got to have the network and the relationships with the community, because it's by knowing and being embedded in community that people actually then begin to trust you. They know who you are, what your belief systems are in regards to health, but also being a role model yourself. When you've got the relationship, the trust and the support of the people in the community, and you know the client that is before you, then it's easy to open up avenues of communication.
Yeah.
But I've got a bike home that my son gave me, so I'll be able to use that too. Yeah.
Okay.
So we go for a walk around the corner.
Obviously at the beginning of the consultation you ought to know what the person's come for, And there are often more than one thing, and it's important to hear that full list. At the same time, I'm interested in opportunities for doing some preventive health as well. So I might start with hearing a bit more about the issues, but I'll also at some point be asking what else could we talk about today, and seeing whether they'd be open to a conversation about smoking or alcohol or something else as well. I might look at the profile of the patient and think this person could really benefit from brief intervention. An example comes to mind, a middle-aged Aboriginal man who's smoking, who's got diabetes and got high blood pressure. I'd love to do some work on all of those with him. At the same time, he tells me that he's very worried about his son. His son's got a problem and he really wants me to deal with that issue, and he also just wants some more scripts today. I really got to drop my agenda and work with his.
You have to let go of who you are in the seat. Not such that I'm a health professional and I do need to have these people change with me. You've got to allow yourself to work with that person, sometimes putting yourself in their shoes, understanding what it is that they may be dealing with at home, and understanding all their issues about the social determinants. Many of us don't think about the social determinants and think that if we work with people, they can do what we want, but it's about working with the people to allow them to actually tell you what they want and fitting into their role, not more what we want as health professionals.
At the same time, be prepared to do a bit of promotion of the opportunities for change and say, how about I see you again soon for a general checkup, or let's do your cholesterol, we haven't done it for a while, or I'd like to do your blood pressure now if possible, those sort of things. So I'd be trying to offer something very small, tangible, something that he sees as value. At the same time, I need to be prepared to give it all up completely and to just work with his agenda, because that's, I think, what being patient-centred is all about. You've really got to be able to work with the patient's agenda. And at the same time, I guess, hold on to hope that we can also work on some change soon. And I often find that patients are quite receptive to that. They're happy to come back for a bit of a check-up soon, as long as they feel as though what they've really come in for today is being adequately addressed.
Oh, yeah.
Going for a walk or that sort of thing.
Oh, yeah.
Fantastic. And do you go for a bit of a walk around the park here or anything like that?
I'll just go around the block here a bit.
Just around the block. I think the lead-in is important. I would be not perhaps going straight into it, but I'd be saying, could we do a bit of a check-up today? Could we, can we do a bit of think about the rest of you today as well? Asking about smoking, alcohol and those sort of things is then a little bit more okay. It's not sort of straight out of the blue. And I guess with that lead-in, with that sort of sense that it's a general health checkup, it's not then a sense that I'm looking for some weakness or I'm looking for something to make you feel guilty or feel bad about, but I'm just asking in a general, friendly way, but I'm doing something that all doctors will want to do, which is look at the whole person and look at opportunities for prevention. I'll take smoking as an example. So there's a lot of evidence that we don't ask that question enough. I still see patients that have been in the practice for a long time, haven't even had that smoking status recorded. I think it's important that we remember to ask that question, but also to keep going, not just ask the question, do you smoke, but how much? Are you ready to quit? Are you interested in quitting? Those are two really vital questions to the brief intervention. And then if they're interested in quitting, then going further and saying you could benefit from whatever it might be. If they're smoking anything more than a couple a day, I'd be offering nicotine replacement therapy or one of the other medications. I'd be talking to them about ways to make that cheaper, to make it easier. I also recognise that most people, most of the time, are not interested in change, so I've got to roll with that. But even if they're not interested, I would say, when you are interested, I'm happy to help. And I might mention that they might benefit from nicotine replacement therapy or something like that. So even though they're pre-contemplators, they're happy users, I would be also taking the opportunity to promote a little bit of the benefits of change, because the evidence is that happy users can be moved more towards the contemplation stage by just a little bit of discussion about the benefits of change.
It's always best to ask the person what they actually want to change, not what the health professional wants to change. And when they tell you what they want to change, that's when you allow them to actually guide you on what they have available in their community, who can support them, including myself as a health professional, but then trying to find out what is the easiest way that we can support. And if it's about weight loss, then it may be just getting old cool drink bottles that are lying around, filling them up with sand, weighing them so that they're the same, and then giving them their own weights that they could use to support them in walking out in the community without having to get a great pair of dumbbells, because it's so good to use what's in their community rather than talking about something that's out of their reach.
If the person is interested in change and we talk about starting nicotine replacement therapy, I'll be quite practical about it. I'll look at ways to make it cheaper. I'll see whether they're on the CTG, practice incentive payment. If they're not, I'll quickly sign them up for that to make their medicines cheaper. I'll get an authority script. I will give it to them there and then and make sure that they can start today. I'll generally suggest that they ring the Quit line, or if they've got access to the internet, look at the Quit Now website, look at the Quit Coach, look at using one of those extra helps. And I'll also offer a consultation 1 week to follow up on some test results or other bits and pieces, and also to see how they're going, because that's also been shown to increase their chances of quitting.
Your clients may not have the funding, finance, to actually make the change in healthy eating. But then it's about thinking, well, how can I work with them to get the best out of what funding they've got, so that they're not buying the takeaways, so they're not buying extra calories such as biscuits and chips, which is what everybody does, thinking, yeah, it's cheap, it's filling. So it's looking at how can we work together better, and then providing them with a referral or a connection to another external organisation to come in and work with the whole group, like it may be a family group or it may be a group where we've got a health setting, such as Derby, where there's a program running, and getting people like Food Bank involved, who will come out and then provide you with the shopping tours, with reading food labels and giving them more knowledge about what's best for them. And what we empower people that I work with is that if we give you knowledge, you then have power and control to make your own choices based on that knowledge that you've got.
Okay. And have you got diabetes yourself?
Yes,
Yeah, right.
I have. Yep, diabetes too.
Oh yeah. And you're using insulin at all?
Oh, what?
Your injections, insulin, are you using insulin at all, or is insulin just on a
No, I
tablet?
take tablets.
I think, like, when we talk to people about changing their risks and the chances of making them live longer, there's many ways that we use different language, and it might be that we put it into a realistic situation. So if we know that somebody's got blood pressure problems, then we will actually talk about it in regards to a tap being turned off and on, but also like putting your finger over the top of a hose and stopping the flow, then suddenly letting go and you get this burst. Well, that's like blood pressure. The blood pressure will build up if you've got a blockage beginning to form. Another one we use is when we want people to understand heart attack. We relate it to the freeway, but I guess you can relate it to any bush road in the community, because what we say is if one car rolls, the blood in your vessel starts to slow down because you've got a partial blockage on that road. It's the same as the blood going through your artery walls. If a truck rolls and cuts the whole road off, you've suddenly got this complete blockage. Therefore, you're in real trouble and you're going to get help really fast because that's when a heart attack happens. So we relate a lot of what we talk to the community in realistic settings, things that they can relate to and understand, and make it really visual as we can. So we're not using a lot of jargonistic terminology. We're actually relating it to everyday living and what's out in our environment and community.
In terms of the sort of language I'd use, I've been advised by Lynn Dimer not to use the word risk, and I use the word chances on her advice. I talk about lowering your chances of death or lowering your chances of a certain problem, worsening of your lung problems, etc., rather than using quite medical language. So taking nicotine replacement therapy doubles your chances of quitting, that sort of language. I'm quite sensitive to how the words I'm using are going down. So if the patient doesn't look that interested or looks as though it's not sort of making sense, then I'm careful to check what's going on there. And I'm super sensitive at the beginning of the consultation and during the consultation that I'm not on the right path with the patient. So if things are not going right, I'm careful to check and not to push too far, really.
When you don't achieve what you want, you start to question yourself. Why haven't I been successful in this? And not too many of us actually self-evaluate. Is it us as the health professional that need to change? Is it the technique we use? Is it the words we use? Why is it so difficult? Is it that we're not seen in the community to be effective with the change making? Sometimes our role keeps us apart from our community, but I find as a health professional that being embedded in your community is the most important thing. Sometimes it's hard, sometimes it's easy, but it's got to come from you and it's got to come from me. The both of us have got to want to work together. And it's only when you're ready that we can do that. I may want it for myself, but it's really about you as the person. And it's only you as the person that is ready to go down that pathway that we can start to create the change that we want to make you better in your health.
And we'll see you again, down the track now. Good on you. All right, well, we'll take you out there.
And our thanks to Dr. Timlay and Lynn Dimer. Back to our discussion, and Jenny, we talked about your success with the 60-year-old businessman. Have you had any, what we might term charitably, we might call them failures or less success?
I think we've all had those, Gerry, but one comes to mind, and she said it is a sad case. She's a 50-year-old lady. We'll call her Miss James today as well. And she's probably 150 centimetres tall. Her BMI would be 35 to 40, and I've known her over 15 years, and it hasn't changed from that point. She lives alone. She's had bilateral hip replacements. She's now facing a shoulder replacement following a fall. She's falling because her balance and strength is so poor now. And she walks with 2 canes. She is depressed, definitely. She's sought out a night job because she doesn't like to appear in public. She had a gastric banding before I met her, so some 20 years ago, and that failed just due to her own sabotage, really, of that. She managed to eat her way through, and she's now certainly well over the weight she was when she faced a gastric banding. I find I can motivate her within a consultation. She will come in crying every time. I see her frequently because she's very dependent on pain medications, and I can motivate within that consultation and have her deciding that yes, she can change. She still overeats, of course, and yet, of course, obviously, over 15 years, I've made no effect. John, what am I doing wrong?
You're probably not doing anything wrong, let me say that for a start, but It sounds as though there are a few factors at play there. I think one of the important ones is she has low self-esteem, clearly, and people who have low self-esteem can quite often get into a place where they really don't think it's worth it. I mean, if I really don't like myself, I'm not going to be motivated to make my life better. And I'm sure we've all heard the way that people describe themselves at times, and it can be heartbreaking. I guess the other thing that is potentially going on there for her is I have to wonder whether she's fallen into one of the traps of the medical model, which is all well and good, but it sounds as though she's often turning to you to at least make her feel good. So it sounds as though she's getting something out of your interactions, which is wonderful. But I'm thinking, you know, if she sees that as the highlight spike of her month or something like that, maybe that's what's keeping her going.
So Jenny, for you, how frustrating is this particular case and this particular woman?
Very frustrating, Gerry, because I feel like there's a limit now to how many times I can keep approaching her about her weight and saying, you know, are you interested in making change, and this isn't working, what could we look towards doing now, you know, is there an advantage for you in change? And I just can't see a way out of it at this stage.
Have you got any ideas about sort of chinks in this lady's armour, so to speak, John?
Look, it might be worthwhile just subtly changing the nature of the question and asking her, what change can you make? And again, there are implications in the way we're asking that. But clearly we're expecting her to make a change, but we're also emphasising that it's her responsibility, and we're wanting her to come up with ideas. The risk that we run by prescribing behaviour change is that, you remember those old cartoons? We had a devil on one shoulder and an angel on the other? Yeah. That's ambivalence. That's the sort of conflict that people are going through. Now, in our role, we're going to likely take the role of the angel. And we're going to say, well, you really need to change, you really need to do something, and we leave them with the devil.
And is that partly the problem? Perhaps if Jenny started to play bad cop, perhaps if Jenny said to this woman, look, everything that I've suggested to you, you've ignored or you've not done. If you carry on like this, you're going to be dead by 2015. Is that what you want? No,
because the risk of that is they're just going to withdraw and she'll hit 2 litres of ice cream again. And that's not what we want. Yeah. They'll look, in the absence of anything else, people will revert to the same sorts of behaviours they've always used to manage stress. And if we're stressing them, that's probably not going to be good at this point.
Jenny, what would you think, how would you think this woman reacted if you were to say to her, look, I think there's only so much that I can do. I think what you really need to do is go and see this bloke called Dr John Forbes, who can talk to you and give you another perspective. He's a psychologist. How do you think she'd react to that?
I have to sadly say that she will say, I've tried that. You know, I mean, and that's a frequent answer that you get as a GP. Is, oh yes, but I did that. Dr X tried that, and I've done that. But I do think it's definitely has to be approached again, and I think for me, it's probably time to approach that again with her.
John, does this woman want to make any changes in her life?
I'm sure at some level she does, but we'll need to work on what are the things that are holding her back, because she really is stuck in that, it's called an approach avoidance conflict. So she'll be, I want to, but I don't want to because I'm not sure what to do, or I don't think I'm worth it, or something like that. And that's really what we need to help people to resolve.
You see this in so many situations, people who are in a very unsatisfactory relationship but are too frightened to get out, people who are hooked on prescription drugs or even non-prescription drugs and are kind of...
What about cigarette smokers,
do you
Olga?
call this the pre-contemplation phase, or is this something completely different, John?
It's probably not pre-contemplation, so they will almost certainly be aware of what the issue is. But the sort of contemplation that they're engaging in is more toward the maintenance of my avoidant behaviour. Part of what we need to do, and the most important part I think, is to get them contemplating change. Because then we can move them further around a change continuum where they're moving toward, after contemplation, a determination. So I am determined to do something. And then into taking action and maintenance. Unfortunately, there is almost always a relapse, but part of what we're doing, I think, is to help the person practice changing. And eventually they'll get good at changing. And that's why the initial approach may be something really, really simple. One woman I saw last year who needed some exercise, I found out after talking to her, was driving her children to school 2 blocks. So all we did was walk 2 blocks. And that was great. It was a lovely time of the year, birds tweeting, her children enjoyed it. Great. Did it change her life? No, but it was a great start.
You mentioned the self-esteem issue, which is something that affects a lot of people. How do you help to raise their self-esteem sufficient so that they will start to make the positive change? If you take this lady that Jenny is looking at, 50 and fat and obese and got multiple problems, how do you raise her self-esteem?
If she came to see a psychologist, we can use things called ego strengthening techniques. But I think one of the wonderful opportunities that GPs have is that they can use their position of power. GPs are rightly regarded very highly in the community. And with someone who has low self-esteem, if a powerful person takes an interest in me and seems to care, that's going to be very motivating. So simple things that I'm sure GPs already do, which is remember their patients, remember their partner's names, their children's names, things like that. Take an active interest. How did you go with this? And I guess in a rural setting, you might even get the opportunity to see them at a sporting club or maybe even just down at the shops or something like that. Ask them there, how are you going with this?
So you
obviously care.
So you're suggesting that GPs need to acknowledge the position of power that they have in the community and use that to affect change in their patients?
I would comment, I think that GPs do underestimate the influence that they can have, and I'm not suggesting, you know, manipulating change here, but I think that to raise the issue of smoking or of alcohol or whatever the issue may be is powerful, and I don't think sometimes it doesn't have to be done more than mentioned, because you are going to hopefully engage this patient and have a long-term relationship with them. So just to raise it and to re-raise it and to re-raise it is more powerful than a lot of doctors would realise.
What I'm interested in is how to get that person that's still saying, but I enjoy smoking.
That's right.
That's my reward. And Gerry, as a former smoker, you'll know that
I did. I never met a
reward.
cigarette I didn't like.
Yeah. How do you kind of get them over that hump?
Yeah.
By raising the awareness of the consequences of their actions and asking them again, looking forward, what sort of life do they expect to have?
Yes, but my grandfather lived to 86 and he smoked since he was 16.
And there are always exceptions to the rule, but what was the quality of his life?
Yeah.
You know, those sorts of things. You know, it's pretty rare, I think, that long-term smokers are going to have a really good quality of life.
Well, you know, the interesting thing is Olga said that line that she used to her patient came rocketing home to me shortly after I quit cigarettes, when I was standing in a group of people and somebody moved into the group and suddenly...
You could smell it.
And I used to smell like that, you know? And
Well, that's
so
part of the awareness
things,
raising.
that's right.
Yeah. That's the cognitive dissonance that we're trying to create.
So would you say then, Jenny, to a smoker patient, do you know, if you gave up smoking, you wouldn't smell as bad as you do now?
I have been known to mention bad breath with smoking, and I think, again, if we won't mention it, no one's going to mention it, and it becomes the all unmentionables, you know, not just regarding smoking, but weight is another one where it's often an unmentionable thing, you know, and I think that you do have to be brave. There's a certain courage in deciding that, you know, I mean, looking in someone's throat because they've got a sore throat and you can smell their breath, and I say, look, you know, did you realise it actually smells really bad?
Pretty
it's
rank.
probably related to smoking.
We run into a thing that's in psychology referred to as the white bear effect. Now, that's best understood by experiencing it. And the way I get people to do that is I tell them, I have to give you an order and you have to agree to obey me without question. But I promise you it's nothing negative and you have nothing to worry about. And everyone agrees, and I say, okay, here comes the order. Do not think of a white bear. And of course, their heads are full of white bears. And that's the problem that people confront, because the more we try to not do something, the stronger it becomes, because we're holding it as a frame of reference. And that's why we need to substitute an alternative. And the alternative we want to substitute and get them thinking about is a healthy alternative lifestyle. So don't try to stop doing that. Try to implement this.
Now, with Jenny's 50-year-old woman with the double hip replacement, the shoulder injury, the whole thing and the low self-esteem. Do you ever, from one consultation to the next, say, now last time we spoke about you doing this and you promised me you were going to do this. What sort of benefits have you seen from that? What sort of difference has that made to your life? In other words, assuming that they've done it.
Look, sometimes it's worked and sometimes it hasn't. And she's had periods where she's improved, you know, and then periods where she's fallen off the horse, and just like a smoker. And I think those, you know, that advice from John is very important, is saying it's okay, you fell off, let's get back on. You know, evidence would say with smokers, the more time you failed, the more successful you'll, you know, or the more times you tried, sorry, the more successful you'll be in the long term. So try again, you know.
Practice,
and I must admit,
positive change.
this lady, that's all I am doing, is just try again, you know.
John, that self-esteem thing that Jenny has brought up with this patient, terribly prevalent with many patients, and not just about their weight and their looks, but sometimes, you know, they're drinking to cover their shyness, or they're smoking to be in a group, or they're using drugs to blot something out that they don't like about themselves. Apart from the general thing of recognising kind of who they are and treating them with respect, how could a GP just in those ordinary consultations help to build a patient's self-esteem?
It's really going to involve you seeing things that they probably hope they have but they're not really aware of. So look for the positives, look for areas that you can praise them. Even if it gets down to, if you've had a really problematic patient, thank them for coming in. And if they miss an appointment, call them, you call them if you have the time, and just say, look, I'm a little bit concerned about you. And it's that actively showing that you care. Because if you treat them as important, they're going to feel more important. And if you highlight that, well, they have done this, they've done that, they've achieved this, it gets them thinking, because they're very likely, I mean, part of what I do with ego strengthening is to highlight the fact that everyone's very good at identifying their shortcomings. We can rattle them off. They're at their fingertips. When I ask people what their positive qualities are, what's good about them, I invariably get the sound of crickets chirping and a tumbleweed rolls across the room. Now, they're just not aware of them. So part of what we can do is to raise their awareness. And it just takes one or two positive comments.
How do you then walk the tightrope between encouraging the patient's self-esteem and therefore their ability to make change, and encouraging the patient where seeing you is the reward and they become dependent on you?
Oh, that's a very fine line to walk down. Look, it may be that if you are getting a sense that they're overly dependent on you, that you need to refer them on to someone. And you can raise the issue about, look, it seems to be that you're just getting benefit out of coming to see me. Call it for what it is, raise it as an issue. If nothing else, it gets them thinking about it. You know, what is the function of this?
Now, particularly in farming areas, it's never actually a good time to be in farming. You know, you've either got a drought or you've got a flood or something in between, or commodity prices are down. And isn't it? It's always one or other of those things. How can a GP, what sort of questions can a GP ask, apart from just getting them talking? As Olga said, how's the crop this year, blah, 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 those kind of things. Are there any other things, questions that GPs could ask that would give them an indicator to the mental state of that patient?
Look, I'd certainly be asking them how their sleeping is. That would be very high on my list. I'd also ask them things like, what does your wife think of you at the moment? What are your children saying to you? Are they avoiding you? Are you being a grumpy old man? That sort of thing. But sleep would be on the issue, high on the agenda. Things like, how much are you drinking at the moment? Is it any more or less? You know, what are you doing to look after yourself?
So, Jenny, as we wrap up this discussion, what are the primary tools that you use in motivating behavioural change, and where are the areas that you can achieve the most success?
I think the things that you see most commonly are the things that you have to keep approaching commonly, and that would be weight, alcohol, smoking by far. The diabetics are a growing breed, and they need constant attention, constant motivating techniques to keep them on track and feeling that they have still control over what's going on for them. So I think I need to hear their agenda, but I'm going to keep trying to suggest in my own agenda if I can with them.
And John, some of the stuff that you've given us on this program, I think will be very valuable to our GPs. But what for you would be the key lessons, the key things that you would say to GPs to do, or the key phrases or questions to use?
I think really the GPs need to get their patient talking. GPs are very good at assessing and evaluating and dispensing advice. After all, that's why we go to GPs. I think there are times though when that needs to be tempered, because the worst thing we can do on occasions is to dispense advice, because then the person can become resistant to that and they can get into that yes but scenario. By getting them talking and getting them thinking about the positives and the negatives of their situation, it's a process called a decisional balance sheet. It raises awareness of everything that's going on in them, and that process is very likely to get them thinking about making a change.
So essentially what you're doing is trying to get the patient round to coming up with their own solution.
Exactly. And as many as they can, because selecting from a menu of options that the person has generated themselves makes it much more likely that they're going to commit to making the change and actually following through on that. And that process also emphasises not only is it their responsibility, but they can do it. And they really will be presenting the arguments for change and the strategies that best suit their lives.
Just before we go, are there any particular resources, either online or books or journals, that you found helpful for the patients that you can suggest, or perhaps helpful for you in terms of learning some more about these techniques?
Look, there is a book that is very imaginatively called Motivational Interviewing by some chaps called Miller and Rolnick, and there's the most recent edition is a wonderful resource because they've taken it from its origins in terms of addiction change and the sort of behaviours that people need to leave addictions behind to alcohol and drugs, and they've actually broadened it very, very nicely into more of the chronic disease management. It's a very easy read and a great resource, and they have resources in there that certainly could be copied for patients.
Yeah. What about you, Jenny?
I think mine are probably more problem-based resources, the Quit line and Heart Foundation information, which I direct to websites, obviously some of the mental health websites, Beyond Blue and the like. Yeah.
And I found an issue of Australian Family Physician in which the theme, it's a 2008, but in which the theme is motivating behavioural change and helping patients make lifestyle changes.
Where's that available from?
And I think AFP back issues are available online. Otherwise, there's a loan copy at Rural Health West.
A loan copy with the long string, it comes back. What about you? What about you've had a long career in country general practice as well. What are some of the tools that you would identify for docs?
Well, I use a lot of the persisting, as you call it, nagging that Jenny does. That. Yes, well and truly. And I try to break making a change down into small steps. So sometimes I think it's a bit overwhelming. You know, somebody gets a new diagnosis of diabetes and all of a sudden someone says to them, you've got to look after your feet and lose weight and stop smoking and stop drinking and change your diet and change your lifestyle and change your menu and make your wife cook in a different way, you know, and they just go, holy crap, that's too hard. Yeah. So what I try to do is say, okay, well, what little change could we maybe make to start the ball rolling? You know, your toes aren't going to drop off next week, but we need to look at all these things. And
it's important, I suppose, John, that they see a measurable outcome of change and that they can will then buoy them to make further change?
Absolutely, and if we can encourage them to begin essentially by practicing making a change, pick the small things that they will get quick and easy results with, that's going to keep them motivated to continue.
All right, fascinating discussion. Thank you both for your contribution
Thank you.
to this particular programme. We're back again on the 2nd of April. We'll be looking at the issue of chlamydia and some other STIs that are emerging as a growing problem for doctors. Olga, good to see you again. We'll see you next month.
Thanks, Gerry.
On behalf of everybody at Rural Health West, I'm Gerry Gannon. Thanks for joining us.